Last night, I admitted a patient to my neurology service for transient word-finding difficulties and right-sided facial numbness and weakness. The entire episode lasted only about a minute and a half, and then it spontaneously resolved. Not a particularly unusual presentation for a patient with an embolic left MCA syndrome. Plus, he had an implantable cardiac defibrillator because of an underlying genetic predisposition to arrhythmias. The patient was only 22 years old, so it seemed like we had a smoking gun to explain his symptoms. As part of his workup, he had vessel imaging, which was normal. Lipids and A1C were checked, also normal. HIV negative, RPR negative, so no other immediately apparent risk for a TIA or a cerebral infarct. And then I saw a test pop back up that one of the residents had ordered, a urine toxicology. It turns out that the kid occasionally smokes marijuana. Now, why is that important to know? What could that information possibly serve to know that this healthy kid smokes pot? We've got a young guy with no major stroke risk factors other than the fact that he's predisposed to having arrhythmias, he has an AICD in place, but still we checked a broad spectrum urine drug screen. And now that information is going to go into his medical record, probably with some sort of documentation that he has a substance abuse history. How does this help out anybody? Next, let's consider a different situation. Another patient that I also admitted last night. A 30-year-old guy who was found unresponsive in his car on the right side of the highway. Paramedics were called, and he was given D50 and Narcan in the field, with limited responsiveness. A head CT on admission showed a massive right hemispheric infarct. He was admitted to the ICU, aggressively worked up for an exam that was out of proportion to his head CT findings. And he also had a urine toxicology sent, positive for THC, amphetamines, and opiates. Was this information helpful? Well, I would say yeah, I think it was. Amphetamines can lead to vasospasm of the intracranial arteries and of the coronaries, predisposing to an arrest or arrhythmias, which can certainly explain his stroke. Opiates could have led to a loss of consciousness, respiratory arrest, or hypoxemia. And if he had injected heroin, this could have led to an endocarditis, which may have resulted in pulmonary embolism or stroke. So a lot of useful data can be gleaned from a urine tox screen in this situation. Now let me ask you this. Would you have tested either of these patients for substance use? Or which substances might you have tested for? Is it necessary to test for a broad range of unique substances? Cocaine, opiates, barbiturates, PCP? Or should we do more targeted testing? How would you go about testing the patient? Do you get their consent? And what do you tell them if something comes back unexpected? This week on the BrainWaves podcast, we'll get into these nuances of drug testing in hospitalized patients. And hopefully by the end of the show, you might think twice about sending that reflex urine toxicology screen. Stay with us.
Just having a positive urine drug screen doesn't necessarily mean that you have a use disorder.
This is Dr. Emily Rosenthal.
You have to actually have changes in your functionality and quality of life and things like that, and your interactions with others to be considered a use disorder. And there are criteria in the DSM for that.
Which is an important distinction to make, because sometimes we'll just reflexively say, oh, you use benzos that aren't prescribed to you. You must have a substance use disorder. So that's why I've asked Dr. Rosenthal to join me on the show this week, because this is exactly her specialty, but in maternal fetal medicine.
Hi, I'm Emily Rosenthal. I'm a maternal fetal medicine fellow at Thomas Jefferson University Hospital, and I have a major interest in substance use disorder in pregnancy.
And not just an interest. She is a funded, enthusiastic, and passionate advocate for patients who have substance abuse issues.
So when I started, I applied for and got an expansion grant for something called Centering Pregnancy, which is a type of prenatal care that's done in groups of women instead of individual care, and it's like a 2-hour session.
The idea of this being that having stronger social support during your pregnancy, you're more likely to remain clean or remain compliant with other aspects of you and your baby's care.
With the idea that kind of that social support aspect may be very helpful for their pregnancy and recovery.
And Dr. Rosenthal works here in Philadelphia at Jefferson, which was her first choice for a fellowship, because it has one of the longest running programs for treating opiate use disorder. And what Dr. Rosenthal hopes to accomplish here, among her many projects, is to improve the way that we treat pregnant opioid users. Instead of using methadone, which has historically been the drug of choice for opiate withdrawal and is complicated by neonatal withdrawal syndrome, she's now gotten approval to treat these patients with buprenorphine, which may be more effective at preventing newborn complications of withdrawal, shortening hospital stay, and it may be better tolerated during pregnancy.
Buprenorphine as well as methadone, and we just got approval to do that. So we have yet to stabilize our first patient on buprenorphine, but we are ready and constantly screening them. And I'm really excited to be able to offer patients more than one treatment option.
And the only reason I got Dr. Rosenthal to come onto the show is because she's good friends with my good friend, Dr. Kelley Humbert.
Hi, my name is Kelley Humbert. I'm one of the neurovascular fellows at the Hospital University of Pennsylvania.
Kelley's one of my co-fellows, actually, and she's the one who put the show together for us this week. So I'll let her take it away. Here's Kelley.
So I guess first and foremost, I know there's been a lot of change in terminology recently. And so maybe just to educate our public on how we should be addressing these terms, maybe you can help us clarify a little bit on how to do this in the best way possible.
Sure. So what was formerly known as substance abuse, the new DSM diagnosis is actually substance use disorder. And similarly, instead of talking about opioid abuse or cocaine abuse, you would talk about opioid use disorder or cocaine use disorder. And it may seem somewhat arbitrary, but actually there are studies that have been done, one of which is very interesting that actually looked at mental health providers, essentially where they read a vignette that had a patient, it was the same patient in both vignettes, randomized controlled trial, and they either used abuse terminology or use disorder terminology. And the mental health providers who received the vignette using abuse terminology were much more likely to have negative feelings about this patient or to think that basically punitive treatments were the right thing instead of therapeutic treatments. I thought it was a really fascinating study because it really shows that the language we use really matters in how we think about the patients that we're caring for.
Do you feel like urine drug screenings or other drug screenings should be mandatory in every patient that you see? And when you do them, how extensively do you screen for different drugs?
So that's a really good question. And I'll tell you, so my professional organization, so the American College of Obstetricians and Gynecologists, recommends screening of all pregnant women for substance use. What I will say is,
I'll jump in here by saying that the American Academy of Neurology does not recommend for the routine screening for substances in the urine for standard patients who come in with a neurological complaint. That being said, sometimes it can be useful to know if a patient who presents with altered mental status just happens to be intoxicated, or if a young person who comes in with an intracerebral hemorrhage, maybe knowing that they've got some sort of a stimulant on board. That can be helpful. And more often than not, in neurology, we would screen these patients using a formal toxicology assay, but that's not the way that Dr. Rosenthal screens her patients in the routine outpatient setting.
What I will say is by screening, they do not mean a urine drug screen. They mean a pencil and paper or a computerized screening tool that asks questions about frequency of use and impairment as a result of use. The purpose of that is to initiate and kind of facilitate a conversation with the provider where you have an opportunity to provide some sort of therapy and referral to treatment. The reason why we don't recommend urine drug screening every pregnant patient is in part because just testing positive for something on a urine drug screen, again, does not mean that you have a use disorder. Of course, if someone screens positive on a screening tool, then you would want to follow up with, some sort of urine drug screen. But I really don't recommend standard urine drug screening for every patient.
In your experience with the pen and paper drug screening that you're describing, how often do you think patients are actually honest with you that it's an effective screening tool?
So Jefferson is a center of excellence for opioid use disorder and pregnancy. Penn and Temple are also centers of excellence, and we have kind of a committee of multiple providers in those three different hospitals, and we're developing a screening package for the city of Philadelphia, basically, to screen pregnant women. and to help providers in that screening. As part of developing that package, I've looked a lot in kind of sensitivity and specificity of these pencil and paper or computerized screening tools. And I'll tell you that there's no screening tool that is both sensitive and specific. The one that is kind of preferred by experts is called the NIDA Quick Screen. It's a computerized test. And that actually is only a little over 50% sensitive, but it's very specific and very accurate. The danger of that is, as you know, for most screening tests, you want to be more sensitive, but we're trying to avoid the potential legal consequences of women having false positives on that.
And not just women, but all patients. And here's where I think things can get a little bit messy, where I'll say that not all tests like this are going to be benign. And not just laboratory or imaging tests. A clinical diagnostic test can be as simple as a question and a response. If you ask somebody if they use any kind of substances, that information goes into their medical record, permanently. If a patient's a truck driver and they take their wife's Vicodin for back pain, say they get into a motor vehicle accident. Cops are at the scene, the patient's employer gets notified, a standard protocol ensues. The patient's taken to the hospital for evaluation of his injuries. If he says he uses opiates or he tests positive, wouldn't he feel that his job could be jeopardized? Even if the accident had nothing to do with having taken Vicodin a few days ago for back pain. This kind of, sometimes entirely benign insight into a patient's personal habits can be perceived as stigmatizing. And you can imagine all the other ways where it might negatively impact a patient's life.
When you first approach patients about possibility of screening, or at least even opening that discussion, if you're not actually yet doing those kind of pen and paper and computerized testing, how do you open the dialogue, and how strongly do you feel about specifically consenting patients to that discussion?
I will say that most of us are aware that we should be consenting, at least in the pregnant population, but most of us do that verbally, which is acceptable, but truthfully, we should be using some sort of actual written and signed consent form, and most of us are not doing that. I would like to move towards that. For the most part, my residents and I do verbal consent. I think the other thing that's really important is sometimes that consent process is just, oh, do you mind giving us a urine to send for a drug screen? Is that okay with you? And that's not really informed consent. Particularly for pregnant women where this could really have very true repercussions, we need to explain to them how this is going to be used and what could possibly come out of it.
This is kind of an interesting point. For the medical providers in the audience, I don't know if it's in your routine practice to consent patients for urine toxicology. I know I don't. From what Dr. Rosenthal said, I kind of wish that I would. And at the time we started preparing this show, I thought that it'd be really honorable of us, as medical professionals, to be totally truthful toward our patients. But the more that I think about it, I'm not as sure anymore. If I really wanted to know if a patient inhaled heroin as the cause of their extensive white matter disease, and the patient denies heroin use and refuses to let me check the urine for heroin, then I may be forced into going down a laborious and an expensive diagnostic algorithm for various leukodystrophies and demyelinating diseases, possibly leading to risky procedures and treatments, maybe brain biopsy. At the same time, if the patient denies substance use and I get that tox screen anyway, it feels a lot like an ambush to me. Oh, you don't use any drugs? Not even PCP or heroin? Well, it looks like we found traces of heroin in your urine. What do you make of that? There's no way that that's a healthy patient-provider dynamic. So I have a lot of mixed feelings about this whole consent process. Obviously, it would be great to consent for these kinds of things. But sometimes, the patients won't want to tell you. And you still really need to know.
So I do think it is problematic that a lot of women don't share this information, and a lot of it has to do with their fear of the consequences. And so a big part of our package is going to be trying to be very clear in what our goal is, that it's not to catch them in this, it's to provide an opportunity for us to provide care that might improve the health of their pregnancy.
This is a great point to make. and it's one that you should use when you're dealing with your own patients in neurology or in whatever discipline that you may practice. Say you've got a patient who comes in with stroke and they use cocaine. Finding out that they use cocaine shouldn't limit their care, nor should it result in some other form of penalization. This may sound a bit cheesy, but in knowing this information, you now have the opportunity to frame this information in a way that can help the patient. If they realize that using cocaine is a risky behavior, then that's a good first step. If you can tell them that by abstaining from cocaine, they can literally cut their risk of recurrent stroke in half, that's also powerful information. More effective than attempting a healthy diet for blood pressure control. But that's just cocaine. Pretty easy to know that it's a bad habit to have. Then there are other drugs that come up on our routine toxicology screen, which may be less clearly harmful to the body.
Marijuana is always a really tough one.
Marijuana, the inhalable, edible plant that's now legally recreational, or at least decriminalized in over a dozen states. And it has several medical indications, and probably only a few adverse health effects, unless you happen to be breastfeeding.
And I'll say this publicly, but when I was in residency, I was sort of trained to kind of tell patients not to tell me if they were using marijuana because it led to involvement of social services and all sorts of things. Since my time in residency, some new information has come out about the safety of marijuana use in breastfeeding, in that it is really not safe to breastfeed if you're using marijuana. The concentrations are very high in breast milk and it can affect the baby negatively. So now, the purpose would be to identify that in order to protect the baby from the effects of the breast milk. But it also helps with counseling of moms. If you continue to test positive for marijuana, you won't be allowed to breastfeed. And so that they have that information and know that ahead of time.
Now, to bring this back to most of what we're dealing with when it comes to neurology or emergency medicine, these substances are only going to affect the patient, and maybe kind of indirectly those around them. But where in this entire process do we decide on who should be screened, and for what reasons? Do we use a questionnaire, or must we rely on a laboratory test? And should we be selective with the patients that we screen, or should it be more universal?
I think probably primary care providers should be screening everybody. And I think, if we think back to med school, at like an annual physical exam, you always ask any tobacco use, any alcohol use, any drug use. And technically that's screening, but it's not really adequate. And so I would, think that the same way that at the initial prenatal visit, we're using these screening tools, that probably primary care providers should be screening everybody too, and have a similar, brief intervention, referral to treatment if people screen positive on it.
Go to the main desk, through this door, make 2 rights, get the doctor's name and location.
So, universal screening. At least starting with a more detailed questionnaire than your simple yes, no, do you use drugs in your social history. But maybe not universal laboratory testing. I came across one investigational study, and you can find this one in the show notes, by Smith and colleagues, where the investigators observed with reasonable reliability that a single question you ask in the primary care clinic can tell you whether or not a patient has a drug use disorder. And that question was, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? If someone said that they did this at least one time, it was 100% sensitive and 73% specific for identifying a drug use disorder. But that was in a primary care clinic, filled with walking, talking, probably neurologically intact people. What if the patient was not neurologically intact? What if they were altered, having a massive stroke or seizing? When we want to send that urine tox screen on them, how can we distinguish pre-test probability from profiling? When is it science? And when is it stereotyping?
I think that this is definitely a slippery slope when it comes to like inpatient medicine and emergency medicine, in making a judgment about somebody as to whether you think that there's a good chance that this drug screen is going to be positive and helpful. And I think we probably are profiling people when we do that in a way that's pretty unfair. I'm not really sure what the answer is. I certainly don't think that everyone who shows up in an ED should have a urine drug screen. And there probably are situations where it's really helpful. Like if someone comes in with altered mental status, for example, you would want to know if drugs were part of that.
I came across a study published in Neurology in 2013 that you can also find referenced in our show notes. It was a retrospective cohort of more than 1,000 patients with stroke or TIA. 40% of the patients underwent a toxicology screen. Now, the authors did not report whether the patients consented for tox screening or what the indication was for the testing. But what they found was that, more commonly, it was the younger patients and it was the black patients who tested positive for substances like cocaine. However, the investigators predominantly tested younger patients, and they predominantly tested those black patients. So whether this increase in prevalence truly reflects a racial or an age predisposition to cocaine use, I don't think we can actually know. What we did learn, however, is that there was some sort of bias in the frequency of testing and the way that we select our patients. That clinicians more frequently tested younger patients and black patients. The authors recognized this disparity in testing and the disparity in the management. Fewer cocaine users were treated with standard of care thrombolysis. And the authors concluded that the best course of action would be to screen all comers for stroke or TIA. While the use of certain substances can raise one's risk of stroke, 2-fold risk with cocaine, 5-fold risk for amphetamines, I'm not sure that I agree with the author's conclusions that we should screen everyone who comes into the ED. And this is kind of what Dr. Rosenthal said. Not everybody who comes into the ED should have a urine tox screen. In addition to the stigmatization, which we already discussed, there are also biases that may seriously impact patient care. A confirmation bias, for example, in which you as the provider might twist the clinical information in such a way that you force it to support your hypothesis. It's the marijuana that's causing my patient's aphasia.
I certainly think that there's the possibility for the drug screen to have a positive result that's a red herring.
So maybe it's not the marijuana that's causing your patient's aphasia. But once you've established that confirmation bias that you have two abnormal findings, aphasia and THC in the urine, you may fall into another sort of bias, a framing bias, in which case you might find yourself committing prematurely to a belief that's absolutely wrong.
And is taken as, oh, we have an answer, and then further workup is not pursued, despite the fact that substance use is so prevalent and certainly isn't causing these problems in everybody.
Like, say you've got a different patient who comes in and they're waxing waning in consciousness, and they've got PCP on their drug screen. You may be biased to believe that the PCP must be the cause of their altered mental status, rather than something else. But then you might neglect the fact that the patient's eyes are directed to one side, and the patient's occasionally twitching. Maybe they're actually seizing.
So I think that a positive result shouldn't preclude other, necessary workup.
This kind of makes you wonder why we have such a blanket urine toxicology screen that includes a lot of substances, half of which bear very limited clinical relevance, and why we send out this indiscriminate and sweeping diagnostic test. Dr. Humbert asked Dr. Rosenthal about this during the interview.
So talking about how we screen patients and how we decide who should and should not be screened at times, there's a lot of debate, I think, sometimes what should or should not be going into a routine drug screen when it's a biological drug screen, I should say. What is your opinion on what should or should not be included and what things are actually relevant?
That's a really good question. I just actually sent out a reminder to the residents at Jefferson like 3 days ago. So actually, most of the heroin in Philadelphia right now is actually fentanyl. Patients don't even know this. They think it's heroin. It's marketed to them as heroin, but it's truly fentanyl. And interestingly, fentanyl doesn't show up as an opiate on a drug screen that tests for opiates. So like our drug screen tests for opiates and methadone, and those are the only two opioids. So we have to additionally order urine fentanyl and norfentanyl, urine buprenorphine, and urine oxycodone. And this gets forgotten quite a bit, understandably, because you think, oh, I ordered a drug screen, I did my job. But there are so many drugs that are not tested on there. And for our purposes, we're treating these women with what we think is opioid use disorder with drug screens that are negative for opiates. And it's because they use fentanyl, and sometimes that wasn't checked. And so I think important to remember that the standard urine drug screen is actually pretty limited as far as drugs that are being used.
Where Dr. Humbert and I work, there are several other important substances of use that have clinical relevance and are not included in the standard urine toxicology. Acetaminophen levels must be ordered separately, but it can be critically important to know because acute Tylenol overdose can be life-threatening. So for me at least, I don't know that I like this kind of a standard all-inclusive drug battery. While it definitely makes things simpler in the emergent setting and is probably more cost-effective, you could end up with a lot of misinformation that leads to all the biases that we've covered. And if I had to choose which drugs I would have for my standard toxicology screen, I would include all the opiates, including methadone, cocaine, barbiturates, benzodiazepines, and ethanol. And I choose these because inappropriate acute management of patients who are intoxicated with these substances, this could be life-threatening, as you're no doubt aware.
Before the 90s, pain was not being adequately treated. And in the 90s, there was this whole movement that opioids are safe and that if you use opioids to treat pain, they won't cause addiction problems. And so there was kind of this swing the other way to start prescribing a lot of opioids.
So many doctors were taught in school that if patients had real pain, and by that typically means pain related to some lesion in the body that you could palpate or see on an x-ray, that if they have real pain of that type, then they could take a potentially abusable drug and the risk of abuse and addiction is minimal to nil.
If patients have legitimate pain, we were taught that they don't become addicted to these medicines and that instead of allowing people to suffer needlessly, we should be much more liberal in our prescribing of opioids.
Even my fellowship director was so bold as to say, pain soaks up the euphoria and therefore you can't become addicted to opioids. That wasn't what I was seeing in my own practice.
And now we're in this day and age where we're talking all the time, like every news article is about the opioid crisis, and especially how pharmaceutical companies and doctors have contributed to it. And so everyone's super afraid to prescribe opioids. I think it's really important that we strike a balance of not inadequately treating pain, but trying to use like the lowest effective dose to give only the supply that the patient will need for that period of time. Because really the problem is when patients have 20 left over.
This actually happened to me recently. I underwent some kind of a gum surgery last summer, a relatively minor procedure. The surgeon carved out a piece of the roof of my mouth. And post-op, I would say that I was pretty uncomfortable. Talking made it worse. But my surgeon told me that I should just take Tylenol and ibuprofen, meds I was already taking almost excessively. My wife Erica had some extra Percocet from her wisdom teeth removal just the year before. And although I felt guilty, I did need something better than Tylenol. Now who's to say that if I got into a bike accident on my way to work, because I bike to work every day, and I'm unconsciously brought to the ED, and they find that I have opiates in my urine, that it was probably my fault because I was stoned on Percocets. How relevant would this finding be? And how do you think that it might have affected my clinical care? I asked Dr. Rosenthal what she thought of this. Do you think it's fair to send a battery like that? I mean, when we send patients down to MRI, we don't send them down for MRI, MR angiogram, MR venogram, tumor protocol. Is it fair to test everybody who comes in for a wide variety of seemingly trivial toxins? Like at Penn, for instance, ethanol and THC and amphetamines are all kind of included in the same tox screen. If I'm concerned that somebody has worst headache of life and I'm worried about like a subarachnoid hemorrhage and vasospasm, right? Like
what
why
matters?
Yeah.
I think that's a really good point, that we could be choosing specific components of a drug screen based on the symptomatology that we have. It comes up in OB too, actually, in that someone who comes in with an abruption or comes in with preterm labor, you know, the drug that we're the most worried about is cocaine. And that's really what we're looking for when we send it in that clinical scenario. And so we may catch someone who's been using marijuana and then their case may get referred to DHS because of that. So I think it's a wonderful idea to kind of split up the drug screen and just test for the relevant items.
Would you take anything off of the tox, like a generic tox screen?
I mean, I think the thing I would consider would be cannabis or THC or whatever it is on a given drug screen, particularly in states where that's now legal. I think maybe for us, the only reason it really matters is for breastfeeding. But I'll tell you, when I was a resident and a patient told me that she was smoking marijuana, I always was like, oh, I wish you hadn't told me that.
As we get near the end of the program this week, I want to bring us back to the two patients I mentioned at the beginning of the show. One guy, a 22-year-old with a defibrillator for heart failure and a stroke, who smoked marijuana. And another guy, a 30-year-old, who was found unresponsive with THC, amphetamines, and opiates in his urine. I asked my residents, why were those patients tested for substances of abuse? And in neither instance did they give me a good reason. Their response was the same for both patients. It's part of the stroke order set. The order set. Now, I've not been shy on the podcast about how opinionated I am. And yeah, I'll admit that I'm still pretty naive about many aspects regarding our current healthcare system. And I could concede that routine screening, rather than stereotyping, is more reasonable for testing patients for substances of misuse. But it's important to at least consider, why are you doing this? What substances are you screening for? Does it help you to know those things? And is there a better way to gather that information?
I think if there's sort of one takeaway from this, I think we just have to be very aware of what the repercussions can be of doing urine drug screens on patients. And I think one of the things that can be really dangerous about it is that patients may be less willing to seek care or to disclose actual problems that there could be treatments for because they're so worried about the repercussions. So I think it's really our duty as physicians to work with patients to address these concerns and to make very clear what the consequences of our screening might be, and to align with them in some way to show that our goal is to provide the best care. It is not to catch them in some sort of criminal act, and to advocate for them to that effect.
That's all we've got on the show for you this week. Hopefully, you've got a little more to think about the next time that you order a routine urine drug screen, or the next time that you document substance abuse or substance use disorder. Be sure to use the correct terminology. Thanks so much again to Drs. Emily Rosenthal and Kelley Humbert for leading the program this week. But if this was not enough for you, please refer to the references in our show notes for more great resources on substance use disorders and management. The BrainWaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. The program this week was produced by Kelley Humbert, Emily Rosenthal, and myself, Jim Siegler. Music for this week's program was courtesy of Montplaisir, Lee Rosevere, and Kevin MacLeod. Sound effects by Mike Koenig and Daniel Simeon. I'm Jim Siegler. Thanks for listening.